for taking our time to attend this webinar. I'm Dr. Prasanna Kumar. I'm hosting this event. With me is Dr. Sam Balu. Dr. Sam Balu is the Scientific Affairs Manager for PGS PGD at Medgenome. He's a trained geneticist who holds a PhD in human genetics from NIMHANS, and he did his postdoc from NIMHANS as well. At Medgenome, he is in the core team of PGS PGD domain right from its inception. He played a key role in developing and validating the PGS test using next generation sequencing. His varied experience includes handling commercial PGS samples, providing technical support for clients, and being an evangelist for PGS PGD services. He is involved right from the site requirement for embryo biopsy to interpretation of PGS results. He has also helped develop custom PGD testing on a case-to-case basis. So we have a very well experienced person with us, Dr. Sam Balu. Welcome to.
Thank you for the eloquent introduction, Dr. Prasanna.
So today's topic that we would be actually discussing is role of preimplantation screening, that is PGS, and preimplantation genetic diagnosis in vitro fertilization. To start off with the basic question, what is PGS, and are there any prerequisites for providing this PGS test here in India?
Yes, a very important question, Dr. Prasanna. So, preimplantation genetic screening essentially is a method for checking for chromosomal aneuploidies. So, what we need for that particular analysis is a biopsy. We remove a few cells from the embryo, then we provide a kit in which the cells are collected. These cells are then transported to the lab at Medgenome, and using NGS, which you mentioned, next generation sequencing, we analyze these embryos and see which are euploid or have the correct number of chromosomes, which are aneuploid, and then based on our findings we recommend, doctor, please go ahead for these embryos as they are euploid. They are going to give you a better result if implanted. So this is what PGS actually offers. So I was talking about embryo biopsy. So biopsy is possible at two stages. One is on day 3 or the cleavage stage. Another is day 5 or blastocyst. So in day 3 you have 8 to 10 cells, out of which one cell will be removed and provided. So our test is capable of single cell analysis. In day 5 you see two different structures. One is the inner cell mass or ICM, and the other is the trophectoderm. I would like to emphasize that the ICM, which is the actual embryo, is not sampled. We sample only the trophectoderm, which is going to be the future placental tissue. 4 to 5 cells are taken, and then they are provided to us for analysis. For the clinicians who are present, there are some prerequisites before we start PGS. The most critical one is to have the PCPNDT license, which allows that PGS and PGD can be done, that the biopsy can be taken at the center, without which we don't proceed. We also recommend using a laser-assisted system because this is the cleanest and fastest method. And the most important person for doing the biopsy is, of course, the embryologist, who is trained in doing either a day 5 or day 3 embryo biopsy, along with which requisite infrastructure like a separate sterile room, freezers, and suitable containers are also recommended.
So the basic question is, why do we need to do PGS in IVF?
Yes. So in the IVF space, PGS is playing a more and more critical role simply because if you look at IVF embryos, the norm is to have more aneuploid embryos. So literature in fact shows that 1 out of every 2 embryos can carry aneuploidies in case of IVF generated embryos. And even when you morphologically grade these embryos as good grade embryos, up to 40% of those good grade embryos can have aneuploidies. So having a screen like PGS for those aneuploidies is critical in helping you segregate and rule out aneuploid embryos and implant only euploid embryos.
I noticed that you are repeatedly emphasizing on day 5 embryo and not on day 3. Is there any significance in the overall outcome when it comes to IVF setup?
Yes, setup. So before I get to that, I would just like to cover a little bit about what are some of the benefits we get through PGS. One is it reduces the overall number of cycles that you actually require to get a successful pregnancy. Then the success rate of the center goes up because you are able to achieve pregnancy with fewer cycles for each patient. Implantation rate overall goes up, and single embryo transfer gets you a higher rate of success. Generally, when there is poor obstetric history, paired implantation is preferred, which has its own complications, twin pregnancies and so on and so forth. Here, singleton implantation rates go up, and therefore the complications of multiple births are avoided, the miscarriage rate is lowered, and it alleviates the reproductive challenge which is associated with elevated maternal age.
You mean to say you are actually addressing the core issue
Yes,
of
yes.
getting the healthy baby
Yes.
with minimal possible time?
Yes, with minimum number of cycles, minimum number of hormonal stimulation. With that, we want to achieve the pregnancy. So, actual data showcases here that the significance is quite high. If you look at an older study which was done in an Italian population, it is close to 25% increase, whereas in an Indian population, which was done in 2016 from Sir Gangara, it is closer to 30% improvement in pregnancy rate.
There is a market difference, as I can see 26% from 26% to 63% in Indian scenario as compared to 42% to 70% in Italian study. Is there any change in the kind of patient pool that were taken?
Yes, in fact, this older study is done with slightly older technology. This is done with a CGH based technology, and the technology which is currently employed is even better and even more sensitive. So what you can actually expect is better percentage success than what is even shown here.
Well, that means to say it can be even better than what is being shown here,
yes.
from 26% to 63% jump in the success
yes.
rate.
We can have even better results than this.
That is very encouraging, I should say.
So coming to your question about why we prefer day 5 and why we strongly recommend day 5. So day 3 biopsies, like I told you earlier, are only a single cell. So in a single cell, we can pretty much give you a yes or no answer for aneuploidy. But we can't tell you whether there is any mosaicism present. And what is mosaicism? Mosaicism is a condition where some of the cells in the embryo are abnormal, whereas some of the cells are normal. Hypothetically, if you give us 10 cells and 5 are normal, 5 are abnormal, it is 50% mosaic. But if you give us a day 3 sample, you're only giving me a single cell to analyze. So it will be a yes or no. It is aneuploid or euploid. Whereas in day 5, since you're giving us more number of cells, we can even tell you the percentage mosaicism. And this is critical when you have to decide whether to go for an implantation or not. And also it has been found that the morphology of the day 5 embryo coincides more with the euploid or chromosomal status much better than the day 3. That is why we strongly recommend day 5.
With this understanding and with this kind of proof of concept that's already available out there, do you recommend pre-implantation genetic screening for all the IVF samples, IVF cases? Is there any criteria for selection of what are the kind of patient pool that needs to go for PGS and should not go for PGS? Is there any selection criteria?
It's a very interesting question, Dr. Prasanna. I would actually like to say that we are actually observing a shift in the mindset of the clinicians who are prescribing for the test. They are prescribing, once they start experiencing the benefits of PGS, more and more of the IVF cases are being recommended for PGS as a standard screen. So it's starting to become more of a standard screen. Because, like I said earlier, a large percentage of these embryos are aneuploid. And this can screen out those. So this is being prescribed more and more from clinicians who have started with the PGS process. So generally, couples undergoing IVF are recommended, especially when the maternal age is above 35, because aneuploidy rate goes up. And those who already have family history of aneuploidy, whether they had a monosomy or trisomy, of course, they are recommended. Very often, we get cases where implantation failure is happening. Parents are normal in terms of karyotype, implantation failure is happening, or there is repeated pregnancy. Even in those, PGS helps alleviate. We have seen cases after 3 implantation failures, doing PGS, next cycle was successful.
That's interesting. That you mean to say PGS is giving the absolute answers why there is a failure and increases the success rate even when there is a repeated failure in.
Yes, we have seen cases with bad obstetric history where a single PGS cycle has helped alleviate the problem. We are able to identify in this case it was an embryo aneuploidy which was causing it. So the next cycle implantation happened and pregnancy continued.
So I remember you mentioning in those 2 cohort case studies different technologies being used, older technology in Italian case and newer technologies. So tell me, can briefly, what are the various technologies involved in pre-implantation gender screening and their comparative advantage?
So one of the oldest technologies which I was referring to earlier is fluorescent in situ hybridization. So this is the problem in this is it's very much observer based. So if you score the sample and I score the sample, for example, we could have differences in score. So that is one of the reasons, and it's very limited. You can screen up to 5 chromosomes at a go, whereas you need to screen all the 46. So with improvement in technology based on FISH array CGH, this was able to screen the entire genome complement, but had other problems. Remember I talked about mosaicism?
Yeah.
Some are normal, some are abnormal. This is very poor in detecting the abnormal and normal cases. You cannot pick mosaicism very clearly. Then we have SNP arrays, which are quite expensive to use and are better suited for things like single nucleated polymorphisms rather than aneuploidy screens. Therefore, the technology which is currently widely being used and incorporated is next generation sequencing. Why? Because it has high precision in detecting gains and losses. It can work with very small quantities of DNA. It can parallelly process multiple samples together, and also what we can do is we directly detect, because we look at any other method, it is all indirect. It is visualization here, SNP based. Here you directly sequence the DNA and give a result. So it is the most accurate.
From this comparative analysis, it's clearly evident that NGS outsmarts all other technology. Do you have any live examples to absolutely say that NGS is the preferred and superior as compared to other technologies?
So one of the main reasons why we prefer NGS technology is because of its high sensitivity and specificity. And at MedGenome, we particularly use the Illumina system, the VeriSeq PGS chemistry, and the MySeq sequencer. And what we are proud of is that the entire process is carried out at our center. So none of this is outsourced. So we are able to control the quality from beginning to end of the process. Okay. So why NGS is preferred? This sample is analyzed using 2 systems. Here it is NGS based, and here it is microarray based. It is the same sample. So if you look at chromosome 7 here, you can clearly see the trisomy in the NGS data, whereas in the array CGH data is barely visible. You may still be able to call it with experience. But interestingly, if you look at chromosome number 12 here, it is showing a 50% mosaicism. Half of those cells are aneuploid and half of those cells are euploid for this particular aberration.
I must confess, even an untrained eyes like mine can actually make out the difference between the 2 graphs.
Yes.
That says it all.
Yes. And imagine, doctor, for a moment, if this case, chromosome 7 was normal, even though it is actually having a trisomy, we would have recommended implantation.
Yeah, we would have missed out.
We would have missed it.
Yeah.
So that is why we recommend and we use NGS technology for PGS.
It leaves no doubt in anyone's mind why NGS is the preferred technology. So we have quite a good number of participants. I must inform that if you have any queries, kindly do type your queries, and there is one as I can actually make out. Yeah. So Dr. Manoj is asking, how much of a difference can pre-implantation gender screening make for my patients?
Okay, quite an interesting question. I believe the question is, of course, how does it improve the success? So here what happens is, as I've shown earlier, there is about a 30% gain in the pregnancy rates. 30% gain in the pregnancy rates when you use PGS as compared to without PGS. So therefore, using PGS screening for IVF embryos is something which is recommended. It is gaining popularity in the Indian market, and it is definitely showing benefits. For example, we have cases where I said we have multiple implantation failures before PGS. After PGS, in the next cycle itself, implantation has happened. So it is recommended and it is definitely beneficial. So as I was discussing earlier with Dr. Prasanna as well, 30% has been achieved with array CGH. With NGS, there is no reason why we can't achieve even more than 30% success.
That's interesting, and the proof is there in the pudding itself. As I said, if there are any queries, kindly do type your queries, and we would be able to actually address those questions. Moving on. Tell me, what is preimplantation genetic disease, genetic diagnosis?
Yes.
And how is it different from preimplantation genetic screening?
Right. So sometimes these terms are interchangeably used, but they're actually quite distinct tests. So preimplantation genetic screening, as what you can see on the screen already, is a screen for all the chromosomes at one go. Whereas preimplantation genetic diagnosis So preimplantation genetic diagnosis is looking at a specific disorder. An example of this would be thalassemia, Duchenne muscular dystrophy, limb-girdle muscular dystrophy, where you know that this is a single gene disorder and you want to analyze the embryo for a single gene disorder. That is when PGD can be prescribed. In fact, PGD predates PGS.
Okay.
Because single cell analysis and single gene disorder analysis was available because it was PCR based. Whereas you needed evolution of technology for screening. So in fact, the first case was done in 1996 for cystic fibrosis. And importantly, the variants should be known from both the parents. So the parents should have a positive family history. You should know their genetic information. Only then PGD is possible. So very often we do a pre-PGD work. And one of the potential benefits here is it eliminates the risk of passing on the disorder from one generation to the next. For example, in breast cancer, BRCA1 mutations are autosomal dominant. So the mother has it. But by doing PGD in an IVF scenario, we can actually give her a child, a daughter, who is normal or has the average risk of the population for developing breast cancer.
I remember recently reading the impact of PGS PGD screening in reducing the Tay-Sachs disease incidence in Jewish population.
Yes.
And almost it is at the elimination in Jewish population. That's pretty interesting. So you are proposing, if we upfront know the kind of prevalent diseases, genetic diseases in the family, you can prepare the parents to screen the same and to prepare themselves for getting a healthy baby by preventing all these abnormalities by doing the PGS. Yeah, interesting. So PGD actually complements PGS in many ways, is what you are.
Yes. So the critical factor for determining PGS and PGD is whether there is a positive family history. So if you're going for IVF, there is no positive family history, PGS. If there is a positive family history, PGD, and on a case-to-case basis, depending on the kind of variant, we can offer both PGS and PGD.
Okay, so it is important to screen the parents for PGD before
pre-PGD workup.
Yes. So you recommend the parents to come even before the first pregnancy.
Very good point, Dr. Prasanna. Yes, in fact, we would recommend wherever possible, before starting the IVF cycle itself, if you have positive family history for single gene disorders, kindly approach us and contact us or the service provider to do a pre-PGD genotyping workup.
Oh, that means the PGD requires a lot of workup upfront. Can you just elaborate more on what is the kind of pre-PGD workup?
So what I have done is actually I've shown how we do the work at MedGenome.
Okay.
So there is this pre-PGD workup which is done, and here what is done is based on the nature of the single gene disorder. So we can detect autosomal recessive disorders, autosomal dominant disorders, and X-linked disorders. So all this can be tracked through PGD. Before we do that, we need to know the family history. And one of the methods, like I'm saying, because there are multiple ways to test for PGD. There's not a single method. Like I said, for PGS, NGS is the best method. But for PGD, depending on the variant and the disorder, different methods can be adopted. One of those methods is carrier method. So first, what we recommend always is that You ask the question, have both the parents or the parent and the donor, because this is IVF, have they been genotyped using molecular methods? If they have, then the next question to be asked is, do they have a first affected child or a close first degree relative? If it is yes, then the most suitable method for such cases is a method known as karyomapping or SNP genotyping. This is a microarray based method. Then, if the genotyping is not done, but they have a first child who is affected with the disorder, we genotype the parents using an appropriate method. This could be a carrier test, this could be a gene panel, this could be an MLP based test. Okay. And then we again go for karyomapping. But sometimes the positive family history is there, but there are no children or no immediate relatives who are affected. There what happens, we have to do an additional layer of testing. So we have to design custom primers, then we have to validate those primers, test them on the genomic DNA, and then go for the IVF embryos.
Oh, the third case scenario actually emphasizes on the fact that why it is so important for the married couples to come upfront even before they actually think of getting pregnant.
Yes. Before they start a family, the testing is critical, especially if they know their family is positive for something like thalassemia or TMD. Very critical.
Yeah, very critical indeed. So, what are the precautions to be taken for sample shipment for both PGS and PGD?
So, one of the things is that your service provider, for example, MedGenome ourselves, we provide a validation checklist. This, before we do the PGS and PGD biopsy itself, make sure that everything is ready. All the necessary clearance are there, the documentation is there, required infrastructure is there, and personnel is there. So, have a site validation checklist and get that approved. And then, based on the center, additional support should be provided. So, it's not just we send a kit. We should be ready to support them. If training is required for the embryologist, that can be provided. If they require a laser to do the biopsy, as we said, laser-assisted biopsy is the best system. Or, in fact, if there is no embryologist who is ready to do the biopsy, the service provider can send an embryologist with a laser to do the biopsy and collect the samples. And for each case, especially in PGD, having a technical discussion before starting the process is critical. So this is a typical biopsy collection kit. This is the one we provide at MedGenome. Of course, the kit includes all the reagents and chemicals as well as the documents, including the test request form, consent form, so on and so forth. So what is there in our kit essentially is a separate rack which has the tubes, the small 0.2 ml tubes into which the biopsy is transferred. But before transferring the biopsy to the tube, certain processing such as cell washing has to be done and cell collection has to be done. So for that you require different buffers, the wash buffer and the collection buffer. These are also present within the same kit. So the kit is very self-sufficient. So one of the precautions which we spoke about is that before starting the process, the kit will have instructions on how it is to be used. And we also provide technical support. So that should be understood well before starting the process, not after starting. The volume is very, very low. 2 to 2.5 microliters is the volume. So it is literally on that tube, one small drop. So since the volume is so small, collection tube should be used carefully. And the sample should not be disturbed. In fact, we strongly recommend only using tubes which we have provided or provided with the kit and the buffers which are provided. No external chemicals need to be used there. The tube should be labeled and the labeling should match what is written in the form. Important is to keep the samples frozen to prevent damage of the cells and loss of the samples because these are critical samples until the pickup is ready. And generally pickup happens in dry ice. So what happens is your service provider generally will handle the logistics component as in to deliver the kit and the sample pickup in return is handled by the service provider. MedGenome does this.
So you mean to say temperature controlled boxes, that is -20 is the one which helps you getting the sample from the site till the delivery of the sample at the lab.
Even cooler than that. Actually, we ship in dry ice. Return pickups are in dry ice just to ensure that there is no chance of doing problem. So we don't even take a chance with -20.
Yeah, that's a tedious work, but yeah, the results are there to see for everyone to appreciate. So, can you take us through the journey from sample collection to report generation? Now that we have learned that it is critical to have temperature controlled boxes, So once that box is reached MedGenome lab,
Yes.
what happens till the time you generate the report and help clinicians to find the answer for their patients who are seeking a healthy child?
So here what happens is, as we discussed, the biopsy is done and the kit, within the kit, the biopsy samples and the documents are placed. Our person from the logistics will pick it up and it comes to MedGenome customer support. So here what happens is, before it is actually registered with us, we have to register the samples and generate sample IDs. Before that itself, we check the tubes for damage. 0.2 microliters in a 0.2 ml tube. So if there's any kind of damage, mislabeling, those samples are not processed, or if they are even being processed, the clinician is immediately alerted that there is something wrong with these tubes. Therefore, please note that we are not sure about what result we will get. This is immediately emailed. So there is no waiting period or lapse in that. So once the samples are registered, they're sent to the lab. The order is booked and they're sent to the lab. You are giving me 1 cell or 4 cells, 5 cells. This is in having picograms of DNA. But in order to do genetic analysis, we need to amplify that DNA at least to nanogram levels, and this process is called whole genome amplification, or WGA. After we amplify the whole genome, we do a quality check. This is another critical checkpoint. So here we have cutoffs both in terms of quantity we should get and quality which we get. So if in any samples failing this checkpoint, immediately again are reported back to the clinician. For example, you gave us 8 embryos, out of which we'll say, doctor, 6 of the embryos have passed the WGA checkpoint, 2 have failed. These are the possible reasons why they have failed, and if possible, please provide us a rebiopsy. And the important thing about this checkpoint is it is 2 days. So within 2 days of getting the sample in the lab, we are ready about the problems. So there's no need to wait for the entire cycle to complete before you find out some samples are not. So this is something we have built in to make sure that real-time updates happen to the clinician.
That's very important, because at the other end, the patient and the clinician will be waiting for a yes or no answer.
Yes. So once that is done, we do a standard library prep, which is done in NGS. We do sequencing, analysis, and then report generation, which is automated. So, like I said, this entire process is done in-house at MedGenome. None of this is outsourced anywhere. In fact, the same PGS team will be participating right from the kit preparation all the way to the report generation. And the reports are triple validated by clinicians, by our lab director, by the geneticists, before it is released to you. So it's triple validated and the process is automated, so minimal manual interference and movement happens.
So there is consistency maintained throughout.
Yes, yes. That is why we have automated the entire process.
So let me just see if there are any queries, questions raised by our participants. Dr. Prahlad is asking, can you do a PGS and PGD test on the same embryo?
Okay, so for this, the PGD case is first, we'll check for the PGD, what is the variant, and then we can also offer aneuploidy screening on a case-to-case basis. So for every case, this is not going to be possible, but on a case-to-case basis, yes, we can do PGS and PGD together on the same sample. So on a case-to-case basis, we'll be able to answer. It depends on the disorder, depends on the variant. For example, if it's a deep intronic variant, then both might not be possible. If it's an exonic variant, yes, generally we can offer both PGS and PGD. This we recommend also because PGD will take care of this particular disorder, PGS takes care of the aneuploidies. So we can cover both.
So it's like an end-to-end solution that you are actually
comprehensive
PGS and PGD. So tell us MedGenome's roadmap to bring clarity around the most important event in a couple of slides, that is birthing. What is the roadmap, how you have planned out to provide the critical service to clinicians to find an answer to their patients seeking a normal child in their lives?
Okay. I think Dr. Prasanna hit the nail on the head when he used the word clarity, because at MedGenome, we have a particular process vertical called Claria, which I'll get to in a moment. So Claria actually is a dedicated suite of tests, right? Battery of tests, which is meant for reproductive genetic health. So what we offer is, we offer carrier screening tests for parents who are planning to start a family or have started the process. And for those who are undergoing IVF, we offer pre-implantation genetic screening and diagnosis, and for pregnant ladies, we offer non-invasive prenatal screening or NIPT, wherein the mother's blood is taken from which the fetal DNA is extracted and analyzed for aneuploidy. So we offer these 3 tests. But at MedGenome, we have a mindset saying that doing the test and giving you a result is not good kind of. In fact, it is seldom enough just that we collect a sample from you and give you a result. That is not enough. Very often, doing the test is one part, providing the results is another part, and each of our tests, if you see in Claria, provides very, very important information. For example, carrier testing will tell you the parent's genotype, which is the starting point for PGD. Doing PGS and PGD will help you choose normal embryos for implantation. And doing NIPT can give you information on whether common aneuploidies are present, along with additional details of microdeletions as well. Now, this is all well and good, but we understand that just giving a result to a clinician is not enough. Very often before and after testing, we have to provide additional support. So what do we provide? In terms of carrier testing, we actually will sit down with you, the clinician, and determine which is the best possible test for this case. Once the testing is done, we will help interpret the results, interpret the variants, and we provide supportive genetic counseling. Even for PGS and PGD, well before the test itself is started, you have to do site validation, you may have to do biopsy training for the embryologist, or provide a laser, or in fact send our own embryologist. Once the test is done, interpreting those CNV charts, interpreting the variant data, again we support you. I myself am involved in this process, along with genetic counselors, because we then have to counsel the patients and we have to coordinate with the clinicians about what is the next step, what can be done. Similarly also, for result interpretation of NIPT, we provide support and we provide genetic counseling. One important point which I would like to emphasize is, since it is a support and we want to benefit the patient as much as possible, the genetic counseling is offered free of cost.
Oh, okay.
And it's on a case-to-case basis. So you can schedule a call with our genetic counselors and have a free of cost genetic counseling session done for your patients. So what we hope to achieve is that by empowering you, the clinician, through genetic testing with technical support and expertise, we want to give you the best possible answers, the most comprehensive answers to the questions you have regarding your patient's reproductive genetic health. So that is what we want to provide, clarity and insight.
That gives a lot of reassurance to both clinicians and the patients out there who are seeking answers for many of their unanswered prayers, if I may say. So one last look at if there are any questions. There is one. Again, Dr. Manoj is asking, can you do a PGS and PGD test on the same embryo?
Yes. So if anyone else also has a similar doubt, we can do PGS and PGD on the same embryo on a case-to-case basis, depending on the type of variant which is being identified. So we can go ahead and do both PGS and PGD.
And another question is, how many PGS testing have you done so far?
Okay, so we have done over 100 samples of PGS. This is post our internal and external validation. So we have done 100 plus commercial samples already. And here what we have found, like I said, very interesting, couple of interesting points is, one is all of them are day 5. Once we counsel the clinicians, all of them are day 5 profectoderm samples. And very interestingly, we have not found the most common chromosomal abnormality, which is trisomy 21. We have found cases of monosomy 21, but no trisomy 21. So that is why PGS becomes important. Because if you had done FISH, you would have looked at only 21 and a few others. Here you will get abnormalities in chromosome 7, 4. So unusual chromosomal abnormalities in IVF. That is why PGS is important.
I understand. I think there's that's a great deal of information that you shared with us. Thank you so much for spending your time in answering many of our queries as well. And just to inform our audience, this recording will also be posted on Facebook. If you have any further queries, you can always write to us. Either Dr. Sam or the support system will absolutely come back and answer all those queries. Thank you so much for your time taken to join this webinar. Thank you so much.